Hi, everybody. Thank you so much for joining today's Breast Pathology Community of Interest meeting. So today in the first half of the meeting, we have a very special speaker joining us here from Belgium. Professor Dr. Van Bockstal is a histopathologist with a subspecialty interest in breast pathology. Her research concentrates on ductal carcinoma in situ of the breast. She received her medical training and PhD at Ghent University in Belgium and her specialist training at Ghent University Hospital in Belgium. She performed a fellowship in breast and GYN pathology at the Erasmus Medical Center in Rotterdam, the Netherlands. And Dr. Van Bockstal currently works as a breast pathologist at the Clinique Universitaire St-Luc in Brussels, Belgium since 2019. She has an appointment as university lecturer at the Université Catholique de Louvain in Brussels, Belgium, and she is the Belgian representative of the British division of the International Academy of Pathology, and she represents the French-speaking part of Belgium and the European Working Group for Breast Screening Pathology. She is the vice chair of the Belgian Working Group for Breast Pathology as a part of the Belgian Society of Pathology, and she is an associate editor of the International Journal of Surgical Pathology. Today, Dr. Van Bockstal will be presenting on lobular carcinoma with tubular elements, a challenging diagnosis that one may encounter in day-to-day practice. So on behalf of the organizing and moderating team, as well as our attendees here today, we would like to thank you for your time in giving us this relevant and very important talk today.
Okay, thank you. So yeah, I was invited to talk about invasive lobular carcinoma with tubular elements. First of all, I'm not a native speaker of English, so I do apologize if I say something silly. Don't hesitate to correct me. So today's topic is a challenging diagnosis, and I've prepared some slides. Yes, okay. Regarding the topic, I don't have any disclosures. So I presented a similar case at the European Conference for Pathology in Vienna last September. And I have foreseen some cases to illustrate, let's say, the theory. So after this talk, you should be able to recognize different architectural patterns of invasive lobular carcinoma of the breast and also distinguish no special type carcinoma from invasive lobular carcinoma with tubular elements based on particular morphological criteria and, if necessary, immunohistochemistry. So before we talk about invasive lobular carcinoma with tubular elements, we should revise what is the exact definition of invasive lobular carcinoma. Now, according to the fifth edition, 2019 edition of the WHO Blue Book, essential elements to diagnose this type of cancer is that it has to be an invasive breast cancer with dispersed or linear discohesive cells. Characteristic, there is a low to intermediate nuclear grade and low mitotic count. And these tumors tend to have a high immunoreactivity for estrogen receptor, and they are generally HER2 negative or non-amplified. And there are two elements that are desirable but not essential, which are coexisting lobular neoplasia, and also ecdyrin can be useful, but it's not compulsory or obligatory to have this. This is not an essential element. And the main reason why this is not an essential element is that the editors wanted to get a document that could be used all over the world, also in countries where immunohistochemistry might not be so easily available. So why is this ecdyrin molecule of importance? Ecdyrin is a protein with an extracellular domain, a transmembrane domain, and then an intracellular domain. And it is attached to a whole series of molecules, proteins, including beta-catenin, alpha-catenin, and so on, to form the link between the neighboring cells and the intracellular cytoskeleton. So if this ecdyrin protein is for some reason deficient or not functional, then this will have an influence on the cell adhesion to the neighboring cells, because these ecdyrin molecules interact with ecdyrin molecules of the adjoining cells. So in this paper written by Matthias Christian et al., there was This was a study on the inter-observer agreement for the histological diagnosis of invasive lobular breast carcinoma. And what the authors observed here was that if a set of cases, mixed cases, so let's say invasive lobular carcinoma, invasive ductal or no special type carcinoma, and then the mixed tumors, which means, let's say, a collision of invasive lobular and no special type carcinoma, was presented to a series of, or a group of pathologists. There was quite some inter-observer variability as for the diagnosis of these different histological types. And this disagreement tended to decrease when E-cadherin immunohistochemistry was also offered. I might get the pointer option. Yeah. So this made already clear that some cases were quite straightforward and some cases had a larger heterogeneity as for the histological type diagnosis. Now, the same group performed a worldwide survey on the currently used histopathological criteria for invasive lobular breast cancer. And they invited respondents to indicate whether they use these different patterns in their diagnosis. And this showed already a high variability, but also the use of immunohistochemistry, including E-cadherin, P120 catenin, beta-catenin, or anything else, was quite heterogeneous among the respondents. So why is it so difficult to diagnose invasive lobular carcinoma? I think there are three main reasons that might cause inter-observer variability. First of all, there is a morphological heterogeneity within invasive lobular carcinoma, meaning that you can have different architectural patterns. There are some morphological mimics, which I'm not that much going to elaborate upon today. And then, very importantly, there are difficult to interpret staining patterns. Now, if we have a look at the E-cadherin molecule, you have an N-terminal and a C-terminal end, and you can have mutations throughout the gene encoding for these different domains of the protein. Not every antibody, as you can see here, there are 5 antibodies listed, but this is not an exhaustive list. I mean, there are many other clones available on the market. But not every antibody is directed against the same antigen or epitope. So you can have antibodies that are directed against an epitope at the N-terminal end, or the majority of the commercially available antibodies is going to target an epitope at the C-terminal domain. And this has been published in the American Journal of Surgical Pathology in 2022, but there are many other studies available that compared different types of clones. And this is one of the images out of this paper where you can see that a morphologically clear-cut diagnosis of invasive lobular carcinoma showed absent staining when an antibody was used that was directed towards the epitope at the N-terminal end. But if E-cadherin was performed, the immunoid was performed for with an antibody against the C-terminal epitope, then there was a retained membrane immunoreactivity, and also for beta-catenin and P120 catenin, there was a clear membrane expression of these proteins. So there was no loss of expression, and for the catenins in particular, there was no cytoplasmic staining, as you can see in other cases of invasive lobular carcinoma. So why is this important to know? N-terminal versus C-terminal E-cadherin directed antibodies. Well, the N-terminal deficiency of E-cadherin might be a new molecular mechanism for the loss of function in invasive lobular cancer. And if you have, in that case, a conserved C-terminus, this will result in normal immunoreactivity patterns when you use antibodies against the intracellular domain of E-cadherin, and also this will be the case for their binding proteins, because the intracellular domain C-terminal end is preserved, it is still functioning, and it will be able to interact with the alpha, beta, and P120 catenin proteins. So caution is necessary when using ecdyrin immunohistochemistry when you diagnose invasive lobular carcinoma. And what was also interesting in this study was that the abnormal protein with the N-terminal deficiency of ecdyrin was frequently observed in mixed type invasive lobular carcinoma. And then I mean not the mixed type as defined by different architectural patterns, but the type of invasive lobular carcinoma that is mixed with ductal or no special type invasive cancer. So in another study performed by Maxime de Schepper, published in 2024, they investigated a whole series of clones of antibodies directed against the ecdyrin protein. And so they noticed different differences in the in recognizing these different domains. But what's most interesting is that, for example, here when they compared a series of cases, including classic type invasive lobular carcinoma and clear, morphologically clear, no special type carcinoma, there were also some hard to classify cases. For example, case number 2, which was eventually classified as a no special type cancer, but with a lobular morphological growth pattern. This tumor showed strong membrane expression for ecdyrin with different types of clones, including beta-catenin, P120-catenin, and there was no ecdyrin staining. But in case 35 in this study, which was eventually classified as an invasive lobular carcinoma, they noted that regardless the retained expression for ecdyrin with some clones, there was aberrant staining with beta-catenin and P120-catenin, and this was associated with the exact spot of the mutation within the gene. So you can have a retained immunoreactivity for ecdyrin if you have an N-terminal mutation. So I will show you now the first case, because I think case-based learning is something very useful. You have an example of a specific issue in a diagnosis, and this makes us remember the theory much more easily. So the first tumor was from a woman, 45 years old. She was already diagnosed with a multifocal invasive tubular carcinoma of the left breast, and on imaging, after this initial diagnosis of the left breast, there was a synchronous multifocal tumor. The foci were between 6 and 20 millimeters in the right breast. And this is one representative H&E slide. So from a distance, we see quite bluish background, so something proliferative going on here. Probably an invasive cancer over here and a big in situ component over here. So if we zoom in on the in situ component, then I think this is not a difficult diagnosis. We see an epithelial proliferation with a clear non-cohesive aspect, which is much more easily appreciated when I zoom in. So you see these slightly clear discrete spaces in between the cells. So the cells in a lobular neoplasia, they are next to each other, but they don't seem to touch each other, which is the contrary in ductal carcinoma in situ. And this is quite a monotonous cell population. You see that the acini are distended by this proliferation, and sometimes there is a discrete nucleolus in these nuclei. And then amidst this extensive in situ component, you see an invasive component. And here we see clear ductal or tubular structures. So let's zoom in on this. You can see that there is a lumen. There are many of these ductal structures, maybe a mitotic figure over here. And then another part of the tumor is diffusely infiltrating. So this is what you would appreciate as a lobular growth pattern. So these cells, the neoplastic cells, are arranged in strands. They are very non-cohesive. But if you have a look at the other area over here, we see that these neoplastic cells, they are tightly attached to one another, and they clearly form glands. So what should we call this tumor? And then in another area where you see the interface of the tumor with the adipose stroma, you see that these neoplastic cells are clearly infiltrative in the fat. And then if we take a closer look, you see that some of these cells organized in strands here have a cytoplasmic inclusion with a nucleus that is a bit angulated and more in the periphery of the cells here as well. There is no high mitotic activity, and I think atypia is maximum moderate. So which type of invasive carcinoma are we dealing with? If we list what we've just seen, we have an extensive background of lobular carcinoma in situ, and we have an invasive carcinoma with ductal structures admixed with those cells arranged in strands. And then we have a moderate atypia and a limited number of mitosis. So let's say this would be like a grade 2 invasive cancer. There is fat infiltration, but without the clear desmoplastic stroma that you would expect in most breast cancers. And then you have the occasional cytoplasmic inclusion. So I think many pathologists would now call for some support under the form of immunohistochemistry. And this is the E-cadherin stain. So from a distance, we clearly have a positive internal control, and we see that this extensive in situ component seems to be negative, which can also be seen here on this zoom. But the invasive carcinoma is also entirely negative, or maybe not entirely, because there is a small hint of very weak, sometimes barely perceptible immunoreactivity. But this is clearly an abnormal staining pattern, because if you compare this to pre-existing ducts or a benign epithelial proliferation, then you see that the intensity has substantially decreased. So even if you have a little bit of staining in the cancer, this is clearly an aberrant staining pattern. And this is also the case in the ductal structures. Although there is a little bit of staining, mostly at the apex of the cells near the lumen, this is clearly an abnormal staining pattern. This is beta-catenin, completely lost in the in situ neoplasia, and there is a bit of membrane staining in the invasive component, but it doesn't really seem to be nicely strong and complete, especially when you compare it with the normal epithelial elements in this breast section. So here there's a close-up, and this is just for comparison, the invasive tumor, and then some, probably apocrine metaplasia and benign epithelial hyperplasia. Here you see what it should look like. So if you have any doubts about the staining intensity in the tumor, always make sure that you compare with any normal ducts or acini, if present, of course, because that might be challenging in some biopsies. But this is your best reference. And so you see that this is clearly an abnormal staining pattern for the beta-catenin as well. So what is the diagnosis? This is an invasive lobular carcinoma with tubular elements. And I call this an architectural variant of invasive lobular carcinoma in Vienna, which has been extensively described in a recently published paper in 2025 by my Belgian-Italian colleague, Giuseppe Floris, in Modern Pathology, where they describe different architectural variants. And I have to correct him and me, because in the future, in the next edition of the WHO, we will not be allowed anymore to talk about variants. We have to talk about patterns, because variants are reserved for all anomalies that can be found in genes after next generation sequencing, and patterns are used to describe the morphology of the tumor. So I would recommend to have a look at this paper published by Giuseppe in Modern Pathology, where they describe pitfalls in the histopathological diagnosis of these morphological patterns of invasive lobular carcinoma of the breast. And his PhD student also wrote a nice paper on the recommendations from the European Lobular Breast Cancer Consortium about the integration of immunohistochemistry in histopathological criteria for invasive lobular carcinoma diagnosis. So as a resume or a summary from this paper, when should you consider invasive lobular carcinoma? Because of course, such a tumor with tubular elements, we might easily mistake for no special type carcinoma, because that's most of the time what we use to make this diagnosis. So if you notice any of the following, linear infiltration and or single cell infiltration of the tumor cells, circumferential, so concentric patterns of tumor cells around pre-existing ducts, like shown in this photo, or when there is infiltration of adipose tissue without a clear stromal reaction, as we had in this case, when there is intercellular discohesion, intracytoplasmic vacuoles is a criterion that I frequently look for if I have a suspicion of invasive lobular carcinoma, when there are uniform monomorphic nuclei, and when there are single cells or small, loosely cohesive cell groups in stromal mucin pools. Associated atypical lobular hyperplasia or lobular carcinoma in situ might also suggest invasive lobular carcinoma. And if you have a Nottingham score 3 for architecture with any of the above, then this should also raise a high suspicion of invasive lobular carcinoma. So we had at least one of these criteria observed. What is next? If the tumor fulfills histological criteria for a classic type invasive lobular carcinoma, then it is just classic type invasive lobular carcinoma. But if the tumor does not meet the criteria, then it is recommended, if you have this available, and of course in Canada this is not a problem, but in some other countries this might be an issue, then it is recommended to perform ecadherin immunohistochemistry. Ecadherin immunohistochemistry in invasive lobular carcinoma it has to be interpreted with caution, because already in 2010 there was a paper published in the American Journal of Surgical Pathology by the group of Imadraka, where they described that up to 16% of invasive lobular carcinomas can present with an abnormal staining pattern, but this could be interpreted by many pathologists as positive. So ecadherin should not be reported as positive or negative. You should really describe the pattern as normal or aberrant, because even if you see some positivity, it can be abnormal, and this is of importance. So if ecadherin immunohistochemistry is entirely negative, then your tumor is probably an invasive lobular carcinoma. If ecadherin immunohistochemistry is not completely absent, you should perform additional immunohistochemistry. So if you have incomplete or versus complete membrane staining for beta-catenin, this could be used as an extra argument to distinguish invasive lobular carcinoma from no special type carcinoma. And the same is true for cytoplasmic versus membrane staining for B120 catenin. Although I personally do not have many experience with that. I don't have B120 catenin in my lab. I use beta-catenin as a backup if ecadherin is difficult to interpret. Just having a look. I think I have 5 more minutes for some cases. Case number 2 is a woman in her 50s. She has a lump in the left breast. And this is just a detail to show you that there are clear ductal structures. And this photo does not allow you to evaluate much more, but it doesn't really look this cohesive. And ecadherin showed a clear abnormal staining pattern, because luckily there is a normal pre-existing duct, and here as well, amidst the neoplastic cells. And you can see that the intensity is much weaker, and this staining pattern is definitely not normal. So this is an aberrant ecadherin. And when we have a look at the beta-catenin, then this is completely lost. There is no membrane expression, which is the case for the pre-existing ductal structures. So this was also an invasive lobular carcinoma with tubular elements. So what is responsible for this ecadherin negativity, and yet there are tubular elements. Well, there is a switch from ecdyrin to picodyrin that has been described by the group of Matthias Christian. I don't have the time to discuss the details, but if you want to know more about this, then I would recommend to read the paper. I think it's freely available in PubMed. I have another case. Case number 3 is a woman of 72 years old, 21 millimeter mass in the left breast. This is an overview. Here you see some details. It doesn't really look non-cohesive at first glance. We have some smaller cell nests, some strands, some groups, not very discohesive, but there is a in situ component that is clearly lobular. Here as well. And here you see the more classic architecture of an invasive lobular carcinoma, although there are some more smaller cohesive looking groups as well, but no clear lumina, although there might be a tiny lumen here. And ecdyrin is entirely negative with a positive internal control. This is a close-up. You have the normal ducts, pre-existing ducts, and then you have the tumor, which is negative. You don't have an entirely negative pattern. You do see some immunoreactivity, but in comparison with the pre-existing ducts, this is clearly an aberrant staining pattern. And if we have a look at other samples of the same tumor, of the same resection, we see that this is more the, let's say, conventional classic architecture of invasive lobular carcinoma, although there are some of these cell nests that have a bit more atypia and that have a slightly more cohesive aspect here, maybe even with a tiny lumen. So a few minutes left for extra cases. Case number 4 is a 59-year-old woman, 11 millimeter mass in the left breast. Here you see clear ductal structures with a bit of desmoplastic stroma, diffusely infiltrating. There is not that much reaction in the fat, but ecdyrin is strongly positive, and also when compared with pre-existing ducts. So in this tumor, there were no cytoplasmic inclusions. There were no other clear characteristics that could hint at invasive lobular cancer. The only thing was that the tumor cells were organized in strands, but overall there was still some cohesive aspect among them. So this is not enough to diagnose an invasive lobular cancer, and ecdyrin was expression was maintained. Case number 5, the last case, is a woman of 60 years old, 15 millimeter mass in the left breast. And here you see a clearly infiltrative carcinoma, but here we see concentric growth around a pre-existing ductal structure here as well. This is a close-up. We see clear lumina, tubular structures, but there is this concentric growth pattern, and there were some occasional cells, not in this photograph, with a clear cytoplasmic inclusion. And here you see that we have ecdyrin staining that is maintained in the pre-existing duct with a clear aberrant staining pattern, slightly positive in these tubular structures. And this is picodyrin. Picodyrin is not necessary to diagnose invasive lobular carcinoma with tubular elements, but if you are an academic hospital, you want to give some extras, and so we have it, and it's really nice because in most, not in all of them, but in most cases that I've seen so far, picodyrin is strongly positive in the tubular elements if they are associated with invasive lobular carcinoma. So the take-home message is that you have to check morphology. If there is a classic morphology, then no immunohistochemistry is required, and you can diagnose a classic ILC. If you don't have classic morphology, then have a look at the ecdyrin stain. If it's completely absent, then it's invasive lobular carcinoma. If ecdyrin immuno is not completely absent and you have any doubts, then you could ask for P120 or beta-catenin. If this is abnormal, then it's probably an ILC. And if it's normal, then it's most likely a no special type or not an invasive lobular carcinoma. So think also about mixed carcinomas. and architectural patterns. Sorry, this is a mistake. I am not allowed to talk about variants anymore. It's an architectural pattern of ILC. And of course, if you have any doubts, it's also convenient to ask for second opinions because they are the best immuno. And then a final slide as a take-home message is that if you have ILC with tubular elements, you should see aberrant E-cadherin in both the strands and the non-cohesive cells and also in the tubules. If you have a mixed ductal lobular carcinoma, you have an aberrant E-cadherin stain in the ILC component, but a normal pattern for E-cadherin in the no special type component. And if you have an invasive ductal carcinoma with a so-called lobular growth pattern, then you will have a normal E-cadherin staining pattern. But be aware of the possibility of N-terminal deficient E-cadherin ILCs. So I would like to thank my colleagues, fellow breast pathologists. These are Dr. Alicia Gonzalez Antelo and Professor Christine Galland, who are forming the breast core team with me. And I think it's time for questions now.
Thank you so much for that wonderful, very educational talk. I can start going ahead with the questions that we have in our chat, or maybe if Dr. Nofek Moses, our moderator, would also like to assist with this part, I could start with the first one. So the first question is regarding this diagnosis, is this the same as the invasive tubulolobular carcinoma of the breast? If not, how do we differentiate with IHC?
That's a good question. First of all, do I have to stop sharing the screen or do I just
That's okay.
leave? Okay.
Either way is okay, yeah.
Okay, so I think that we have a few papers from the past about tubulolar carcinoma. And the problem with, let's say, those papers published between, I don't know, 95 and 2015, is that E-cadherin immunohistochemistry was frequently reported as positive or negative. But we don't know when it was reported as positive, whether it was normal pattern staining or abnormal pattern staining. So it's very difficult to rely on those studies because some reports reported that tubulolar carcinoma was E-cadherin negative, and others reported that it was positive, and it's all very confusing. So I think if we talk about invasive lobular carcinoma with tubular elements, it's probably just another name for what some pathologists used to call tubulolar carcinoma. The thing is that we just have to agree upon a particular name. Now, I was not involved in writing the WHO Blue Book Next edition, but I've heard that the editorial board deemed it not necessary to recognize it as a distinct type of invasive breast cancer, and it will just be reported as one of the possible morphological patterns within the invasive lobular carcinoma chapter. I hope that kind of answers the question.
Great. The next question is, but although I think it was answered already, is beta-catenin IHC useful to be added to P120 as a panel in challenging cases of lobular carcinoma? We have P120, but not beta-catenin.
Aha, okay. Well, I think it depends on your personal preference and experience. I think beta-catenin and P120 catenin are quite equivalent. I find sometimes P120 catenin difficult to interpret, especially when the cells are very small, because you have to distinguish cytoplasmic staining from membrane staining. Whereas in beta-catenin, you're looking for loss of expression, like with E-cadherin. For the real challenging cases, it's super useful to have probably all three, E-cadherin, beta-catenin, and P120 catenin, but not all the labs have that luxury. So I think it depends on personal preference and your experience. If you have one of these immunos, you just have to know how to interpret them. So if you have that rare case where you're really not certain about how to interpret the P120 catenin, you can always send it out to another lab who has the beta catenin. I don't know whether it's really a must to have both stains. That depends really on your personal preference.
And then, sort of a similar vein, can beta-catenin replace E-cadherin entirely as a sole IHC marker for invasive lobular carcinoma?
That's a good question. I think it might be dangerous because if you have a mutation in the gene encoding for the E-cadherin protein that is causing a non-functional N-terminal part of the protein, then your C-terminal domain, which is intracellular, will continue to be functional and will be expressed and will be able to interact with beta-catenin and P120 catenin. And beta-catenin will be absolutely normal. But this will also be the case probably for E-cadherin if you use an antibody that is directed against an epitope at the C-terminal unit. So I think that's there might be a danger for some invasive lobular carcinomas because despite the characteristic morphology, they will still show retained beta-catenin expression if the mutation is near the N-terminal part of the protein. But again, then you will also have conserved E-cadherin expression. So I can't really answer that question. I don't think anyone has looked into that in an objective way by studying a large series of tumors, actually.
Okay. Should we stop reflexing to E-cadherin IHC if by morphology it is clearly lobular? It seems to be standard practice in our institution to do E-cadherin IHC even if it's clear-cut lobular by morphology, and there's often the rare case of aberrant E-cadherin expression that throws a wrench in the diagnosis. Is the paper that you cited the best evidence to convince people not to do E-cadherin IHC?
It's a paper written by a group, so it's a consensus, and I'm quite certain that not all authors agreed in the same degree. But I think that as is currently in the current version of the WHO is mentioned, abnormal E-cadherin immunohistochemistry is not a requirement to diagnose ILC. So you can definitely diagnose ILC by morphology alone if there is no doubt about it. If your institution routinely performs it, I don't think it is a mistake. If you have the means to do it, then I think you can definitely continue because as the previously cited inter-observer study shows, there is still, even among experts, a considerable inter-observer variability in the morphological diagnosis of ILC. So I think if you have the means to do it, that's my personal opinion, it should be encouraged to do E-cadherin on all cases that are suspected to be invasive lobular carcinoma. So it's definitely not wrong. But if the question is, can we diagnose ILC without immuno, then the answer is yes. But maybe just to avoid the odd missed case, because some NST carcinomas can have a bit of a lobular growth pattern, it might be useful to do the E-cadherin stain, but it is true. Then you should be aware that E-cadherin is not always entirely negative. So you have to know how to interpret the immuno.
So sort of, I have a question just to follow up on that. So what do you do in the situation where E-cadherin is ordered on an otherwise like classic looking ILC and it shows retained expression? Like how do you then classify that?
Okay. I think one of my supervisors when I was a trainee said morphology first. And I tend to stick to that. I mean, if you have, I'll just show the list again, just a minute. It was here somewhere. Here. if you have all these suggestive morphological characteristics, then I think you can stick to ILC, even if ecdyrin is positive, because we know that you can have retained expression, which can be quite strong, because of these mutations, for example, in the N-terminal domain. And this definitely when you use an antibody that is directed against the C-terminal domain. So in that case, you will have non-cohesive architecture because the cells cannot interact anymore with each other, because it's the extracellular domain of the cells of the ecdyrin protein that is non-functional. So you will have non-cohesive or discohesive architecture and all the characteristic morphological features. So I think we should not rely too much on immuno. It can be of help in those cases where we have a doubt. But if for you it's a morphologically clear-cut invasive lobular carcinoma, and you just ask the immuno because of routine procedure, then if it comes back strongly positive, then I would still diagnose an invasive lobular carcinoma. So maybe my take-home message was a little bit too much black and white. But let's say that the majority of the cases will have an aberrant expression pattern. It is also useful if you know which type of antibody that you use. So have a look at the clone that you use in your lab and find out whether it is directed against the C-terminal or N-terminal part of the ecdyrin protein. Was that a sufficient answer?
Yes, absolutely.
Wonderful.
Thank you. That's
Wonderful.
really
I
helpful.
wanted to ask also a question, if it's possible. First, that was an outstanding presentation, so practical. Thank you for that. I wanted to ask you actually about the biological characteristics of ILC with tubular elements. Do we have actually data about the biology in terms of overall survival, the metastatic predilections, the biomarkers expression of those? Are they biologically distinct group? So that's one question. And the second question, side question, is would you ever use NGS or another molecular technique to adjudicate difficult cases?
For the first one, for the first question, I think you already gave the answer. To my knowledge, there are no large series that have had a look at that. Because as I said, the older papers that reported tubular carcinoma, they were not always, I think, they were not always describing invasive lobular cancer with tubular elements. Those series were probably contaminated by a lot of mixed, no special type invasive lobular carcinomas. So we cannot rely on those data. So I think if anyone has the time and the means to do a study, this is definitely something that should be done in the near future in a either retrospective or prospective way, or both. Retrospective is, of course, easily done because the data are already there. Well, they need to be collected, but in the prospective way, you need to wait a lot longer for outcome. But I think both of them would be useful to have some kind of registry and have a look at that. And then for the next generation sequencing, well, personally, I don't do it because it's molecular analysis in Belgium is not very well reimbursed. It's only reimbursed in some specific indications. So definitely not for this. And I also think that CDH1 mutations have been described in no special type carcinomas. So it's not because it all depends on the area in the gene where you have the mutation, whether this is going to cause a clear invasive lobular carcinoma as we know it. But I can provide you with some papers on this topic if you would like. I don't know the authors by heart,
Yeah,
unfortunately.
sure. Thank you so much.
You're welcome.
I think we have one last question, it looks like, in the chat. So in terms of LCIS, I guess in your institution, which patterns at the resection margin would lead to additional treatment?
For the in situ component.
Yes.
Yes, okay. Well, if atypical lobular hyperplasia, or let's say the classic type of lobular carcinoma in situ is in contact with the margin, they won't do an extra resection. They will only do that if it is pleomorphic lobular carcinoma in situ. Because for the pleomorphic lobular carcinoma in situ, or for, let's say, a very florid lobular carcinoma in situ, where you do not have the atypia of pleomorphic LCIS, but you do have a very extensive proliferative LCIS with perhaps some focal necrosis, there they will do an extra excision, but they won't do it for the classic type LCIS or for atypical lobular hyperplasia. And also, it depends, of course, from patient to patient. We had a couple of weeks ago an elderly patient, which was who was a very fragile woman, and she had an invasive lobular carcinoma where there was focal pleomorphic lobular carcinoma in situ in contact with the margins, but there, let's say, the general status of the patient did not really allow for an additional surgical intervention, and there it was decided upon to just perform radiotherapy. But in theory, if the patient is fit, they will do an additional excision if pleomorphic LCIS is in contact with the margin.
Awesome. Thank you so much. Thank you so much, Dr. Van Bockstal. That was an excellent talk, very relevant and very useful for day-to-day practice. And I think we had a very nice discussion from that as well. So thank you again so much for your time.
You're welcome.
And I will hand it over now to my co-organizer, Jessie, and we'll start with the case presentation portion of this meeting.
Thank you, Rachel. So next up, we have Dr. Gillian Bethune. So Gillian, if you'd like to start.
Yes, so I am a pathologist in Halifax, Nova Scotia. And today I'll be presenting this very boring title, but hopefully an interesting case, interesting breast case in a young woman. And really, I've never seen anything like this, and just curious to see if other people had seen something like this, and to share it around what the final diagnosis was. So if I can move to my next slide, oh, there we go. So this is a 22-year-old university student, otherwise healthy, previously healthy, and she presented with a left breast lump. And this is just to show you that this all started in 2022, and I'm going to take you through her multiple biopsies and surgeries, culminating in the last surgery, which was very recently in 2025. She initially had a core biopsy in late 2022, and this is what it looks like. So on the left, the low power view, multiple fragments of what many of us would say looks like a fibroepithelial lesion. And then the next two images are just higher power views. So really, it looked like evenly dispersed, benign appearing ducts with increased stromal cellularity, but without really stromal expansion in any way. And if you look closely, sorry about that, if you look closely down here, there were a few areas where the cells had some mild atypia and there were increased mitotic activity. Keeping in mind that this is a very young woman, 22. So she went on, so this was diagnosed as a fibroepithelial lesion with increased stromal cellularity, and noted that there were increased mitotic activity, so lumpectomy or an excision was recommended. And the mass was 6 centimeters in size. This is a couple of images from her lumpectomy specimen. So essentially they shelled it out. You can see the margin along here. Well circumscribed mass. There was very little or no permeation into the surrounding fat. But on this image, you can see that it looks more typical of a phylloides tumor with the architecture, some stromal, what I call stromal expansion. I don't know if that's a term that anybody else uses, but there was no stromal overgrowth per se. And if we go to another area in this 6 centimeter mass, there was some cystic change over here, but really I'm trying to show you that this was a very well circumscribed mass. Higher power, we can see a very cellular stroma, again, benign ducts. And the cells here can hardly be described, in my opinion, as spindle cells, but they're small stromal cells with some, what we thought was mild to moderate atypia, stromal expansion, and a very high mitotic rate, which you can see here. Mitoses were up, I think it was somewhere between 30 and 40 mitotic figures per 10 high power field, so a very high mitotic index. So when I'm thinking about making a diagnosis of phylloides tumor, obviously I know in the criteria in the WHO that age is not really listed, but in reality, I feel that age somehow does have an impact on the likelihood of making the diagnosis of borderline or malignant phylloides tumor. And then when you look at the criteria, I know it's probably evolving, the criteria for making a diagnosis of malignant phylloides tumor, but this tumor certainly didn't have all of the criteria listed. Like, it wasn't permeative, there was no stromal overgrowth. The atypia was what we thought was mild to moderate atypia. Now there was a very high mitotic rate, and no malignant heterologous elements throughout this lesion. So the final diagnosis here, and this was actually sent out for a second opinion just because of the very young age of this patient. I think I've made a diagnosis of benign phylloides tumor in someone this young, but I've never made a diagnosis of borderline or malignant phylloides tumor. So I was uncomfortable with that. But in the end, it was called phylloides tumor, at least borderline malignant potential. There were a couple of margins that were positive. And so there was a long description and a re-excision was recommended. Unfortunately, for unknown reasons, that didn't happen until 3 or 4 months later. And I will show you that now. So in the re-excision specimen that happened in early 2023, there was no well-circumscribed distinct mass, but there was an area that was about 3 centimeters that was described as abnormal and firm. And this is what it looked like here. So these are terminal duct lobular units very close to the margin. And then you have this area here with something going on in the stroma, at least. And it appears to be involving terminal duct units and at least pushing them apart somehow. This is what it looked like in the middle of that area on high power. So again, we have residual benign ducts, and then this very similar appearing highly cellular stroma that's very highly mitotically active and moderately atypical. And if I just go back, and now, so that was this area. Now I'm going to highlight in on what on low power looked like, maybe normal-ish terminal duct lobular units in a young woman. This was the area from that periphery. And you can see here, we've got something similar going on in the stroma, mitotic activity, atypia, it's kind of pushing apart the ducts here. And that was, again, encroaching on the margin of this re-excision specimen. So this was called recurrent/residual phylloides tumor. The abnormal area or the residual atypia was 5 centimeters in size. And in our comment and description, we basically said that we felt that because of what appeared to be a regrowth or recurrence in a very short time frame that was encroaching upon the margins, maybe this would be better considered as a malignant phylloides tumor and treated as such, given the fact that she was still, or she's a very young woman. And there was a discussion with the surgeon about this. Again, the anterior margin was positive, and the deep margin of this re-excision was very close. At one of these points, the lumpectomy or this one, we had made a comment to say, it's a very unusual diagnosis in a young woman, perhaps referral to genetics might be considered. And I was kind of thinking like, phalloides tumors and P53 mutations or Lee-Fraumeni kind of familial syndromes. That was what was going through my mind at that time. Following this, because of the margin positivity, she had a nipple-sparing mastectomy, which had a single duct with that similar kind of atypia in the stroma. And that was all that we saw in the mastectomy specimen. So the patient was referred to medical genetics, given this diagnosis in a very young person. And meanwhile, during the following kind of 6 months or so, the tumor recurred again in the chest wall after the mastectomy. And she had a very fast growing 13-centimeter mass that had arisen at the mastectomy site. So that was removed in addition to the nipple because she originally had a nipple sparing mastectomy. Just show you quickly what the nipple, this is a section from the nipple, here the lactiferous ducts. I'll just draw your attention to this area right here with these atypical stromal cells, mitotically active, not really forming a mass, but it was just noted, which was very unusual. And then this is the chest wall recurrence with this 13-centimeter mass. At this point, there were no glandular elements anymore. Here's the skeletal muscle on here, very close to the chest wall. And on high power, it's sort of an undifferentiated tumor, mitotically active, moderately atypical. So this was called a malignant phalloides tumor. And to bring it all together, I have one of the multiple IHCs were done throughout this time, none of which were contributory other than this particular one. And you'll never guess what it is. I don't think anyone will guess what this IHC is. It has to do with her genetic testing that she underwent. And so this IHC is actually BAP1. There shows loss of BAP1 here in all of the stromal tumor cells, including the ones around the nipple. So normally, normal cells, these are some control, like I think this is a vessel, maybe lymphocytes here. So if it, normally the BAP1 should be expressed in all these cells. So to bring this all together to finish up, this young woman actually has something called a BAP1 tumor predisposition syndrome. And if anyone on the call does work with melanomas or mesotheliomas, maybe you're familiar with this. I was not particularly familiar with this tumor syndrome or this IHC. But BAP1 is a tumor suppressor gene. Its role is in DNA repair, and there's an autosomal dominant pattern of inheritance for this syndrome. So there's inherited loss of one copy, and then the second copy is usually somatically lost somehow. Germline BAP1 mutations are associated with multiple tumors, the main ones really being uveal melanoma, particularly at that site, mesotheliomas, and clear cell renal cell carcinomas. There are no reported cases of any fibroepithelial lesions or phalloides tumors associated with this syndrome. So as far as we can tell, this is the first one that's at least, well, I'm sure there are others, but I haven't read about any. You can test for BAP1 loss by IHC. We do not have it in our lab. It was sent out. And somatic variations are also common in mesotheliomas and some melanomas as well. So that is a routine test in some of these cases. So just to finish off, this young lady has a malignant phalloides tumor that we feel is most likely related to a familial syndrome in BAP1. Her latest surgery actually was an abdominal wall recurrence that has been resected. However, at tumor boards, this was favored to be a recurrence that arose kind of from tumor seeding at the chest wall versus an actual true metastasis. She's had radiation and currently no signs of recurrence or metastases. And her father, interestingly, has a history of uveal melanoma, so that familial that family history was not known before, but now there's been genetic counseling for the whole family. And this young lady has seen dermatology and ophthalmology with no evidence of other tumor sites. So that is my case presentation, and welcome any comments or questions.
Thank you. That's a fascinating case. We've actually got lots of questions in the chat. So I will proceed with those questions. Just let me go back a little bit. So the first question is about, I guess this is really for the whole group, as in how many people are using the new refined criteria by Turishvili et al. So I don't know how we can, if we can put up our hands or something. Do you use the...
This is for making the diagnosis of malignant phyllodes tumor?
Yeah.
Yeah.
Maybe Jenny can help with the polling online. If Jenny is on the call, maybe she can create it. Let's discuss the rest and we can get back to it with the poll.
Yes, I could answer the next one. What made you think of BAP IHC? Is that the next one?
Well, there was a question about whether you perform molecular analysis and if it revealed a TERT promoter mutation, or, but I guess you kind of covered that already.
Yeah, we actually we did not do any molecular testing other than the IHC that we sent out for. We have put in a couple of those reports, like the recurrences and things, that if they requested it, we could send it out. But none of the clinicians have requested any molecular testing to look for any other. So we've just left it as is, because that's what those tumors, even though she is a very unique case, they're not a reflex indication for molecular testing at our site. So we're just kind of guided by clinicians there.
And the next question is, what made you think of BAP IHC testing in the first place?
So that was, I guess I skipped that part of it. She did have the genetic testing done, and I don't know whether us putting it in the report kind of prompted that, or whether the clinician would have anyway given a diagnosis of at least borderline phyllodes in a young woman. But she went on to have genetic testing, and that came back as having a BAP1 germline mutation. And then she had a recurrence, and nobody wrote that on the requisition or anything. But I looked up and I saw the clinical note from the genetic counselor that said, oh, we've had this long conversation with this patient about what the findings are, and we don't know that it has anything to do with her breast tumor. And then I was like, oh, well, maybe we could just do the IHC just to see. And it came back as loss. So it wasn't my brilliance that I didn't think of doing the BAP1 IHC, like, off the top of my head. She had that diagnosis on the genetic screening, and then we did it.
Right, I see. Okay. And are there any targeted systemic therapy available to her?
My understanding, I actually don't know if there's targeted therapy. I don't think so for this particular tumor syndrome. And she's not planning to have it. She's had radiation, but she's not planning to have any chemo or anything, according to the surgeon. So hoping for the best, I guess.
I actually want to say that when you started the presentation, it reminded me of cases I had a couple of years ago from a very young patient. She was 28, and she was known to be a Li-Fraumeni patient. So she had a germline mutation in P53, and this was brought to attention based on just a history of mother dying very early from breast cancer. And her tumor was small. It was, I think, under 2 cm of phyllodes tumor without expansion or significant expansion of the stroma, but there was a high mitotic figure, mitotic count, and a moderate to severe atypia. And at the time I actually searched the literature, there were not a specific modification for genomic syndromes in phyllodes tumors. So I called it at least borderline phyllodes tumor at the time, but I said that in this context, we actually don't know what is going to be the biological behavior. And yeah, I left it with that. But it reminded me of that case of mine immediately. But thank you for bringing it to our attention. I would definitely, we have BAP1 and I'm going to use it from now on.
I think the experience is similar to mine, where when you have something that's clearly a malignant phyllodes tumor, that diagnosis is easy. But I think we all struggle with those cases where particularly in a young patient, or where things are just looking weird, right? And you're like, well, it does not have all, even 4 criteria out of 5 for a malignant phyllodes tumor. It has less than that, but you don't feel comfortable at all just calling it and then next case. So I think these types of cases really have to be shared around and have to be, written with comments. And this is a case example of where there was a very fast recurrence. And so, you don't know about some of them, but yeah, thanks.
Yeah. And with some of these syndromes, actually, it's not advised to radiate. So, for example, for leishmaniasis, radiation is usually not recommended. Anyways, I think that Jenny has the poll ready, right? Yeah, so it looks like most of our attendees that responded are not currently using the modified, more relaxed criteria suggested by Golisa Turishvili et al. But we might see some changes in the upcoming WHO book. Yeah, I'll put in the chat 2 review articles that were recently published about phyllodes tumors.
Miriam, you have a question?
Not a question, more as a comment, because when the latest WHO classification came out, and personally I had an issue with it, and Golisa did as well. So we did like an internal review, I think went back 20 years, and we looked at how this would change our diagnosis if we were applied this retroactively. And obviously it dropped down a lot of malignant. I think it was like 12% of malignant would kind of drop down, but things would never get upgraded. So you would go from malignant to borderline, but not the other way around. And one of the cases that we had, which was, I think it dates back to like Francis O'Malley time, that we managed to get slides and review it, because we reviewed all the cases that we didn't sign out ourselves. It was very similar to this case. There was no stromal overgrowth. There were not even leaf-like architecture, but it was very methodically active. It had cellularity and kind of at least moderate nuclear atypia. And when it was re-excised, there was a small recurrence, but patient underwent mastectomy, but it had a very aggressive clinical course. Unfortunately, patient developed like visceral mets that were followed institutionally, I think, until 2015. And then when she developed brain mets, that's when when she was transferred to a hospital, or the care was transferred to a place that had neurosurgery, which we don't have here at Mount Sinai. So we kind of lost track of how this went, but just looking at the clinical course, it didn't really look like there was going to be a very good outcome. So when I presented this at ASCAP, there are a lot of institutions coming up and a lot of people saying, yeah, we kind of don't agree with the most recent WHO, and maybe we need to pool this and look at this in multi-institutional way. And that's how the new criteria came about. So here we always look at things of not just, because the new criteria are all or nothing, and it's never like that in practice. You never get, you rarely get a malignant phyllodes that clicks off all the criteria for malignancy. There's always a criteria here or there where it falls between the categories of maybe borderline and malignant. And it kind of goes back in the other way. When you have a benign one, there's some criteria that may fall into borderline category. And then, you just have to write these lengthy comments saying, it has these features, but then these are more concerning features. And therefore, that's why we may, recommend to revise the margins and so on and so forth.
So would you say that the clinicians that you work with are aware of these nuances, or do they just want you to tell them, categorically what this is?
Well, one of the surgeons who really has an interest in phalloides, she understands the nuances. So last week when we had a case discussed where it was one of these, cases where most of the features would fall into the benign category, but there were 8 mitoses per 10 higher power fields, and cellularity was more than just mildly increased. And it was shelled out, and we did recommend more than 1 centimeter margin. The original surgeon was like, "Oh, we can just follow this," and that's where this other surgeon had interest and be like, "No, we don't just leave this and monitor. We go back, revise the margins, achieve that 1 centimeter line just to be safe," because the patient was like 24, 25, so she was really young.
Well, thank you very much. That was a fascinating case and obviously generated a lot of interesting discussion. So moving on to the next case, we have Dr. Boris Virine, and who's going to present his case. Boris?
All right. Thanks to Dr. Van Bockstal and Dr. Bethune for your presentations. They were really interesting. Mine's a little bit less unusual. So I'll be presenting a case here of a 62-year-old otherwise healthy female who had a screen-detected left breast mass identified in April of this year. And on ultrasound, they found a 16 millimeter mass that was heterogeneous, solid with the calcifications. They also did a mammogram. And then on subsequent MRI, they described as an ill-defined spiculated heterogeneously enhancing mass that was measuring 14 millimeters. And so this is the core biopsy that we got. So we have an infiltrative carcinoma here. And it's solid nested with some high-grade nuclei. And a significant number of mitotic figures that are kind of seen throughout. And in a different area, also showed a considerable amount of tumor infiltrating lymphocytes. And so this was reported as an invasive breast carcinoma, grade 3. It was low ER positive, PR negative, HER2 1+. And because there was no definite in situ component, to confirm breast origin, the pathologist also stained for CK7, which was strongly positive, GATA3 and SOX10, which were both patchy positive, and ECADHERIN was retained in this case. The patient went on to have neoadjuvant chemotherapy with dose-dense ACT from May to September of this year. And on post-treatment imaging, was found to have a significant response with the tumor decreasing in size from 14 to 5 millimeters. All right, here I just I'm bringing up the MRI images to illustrate the significant response that the tumor had. So the patient proceeded to have a left breast seed localized lumpectomy and sentinel lymph node biopsy. And so this is a specimen that I received from the lumpectomy. You can see the seed site over here, and then the invasive carcinoma just below it. And it's actually quite well defined. Then looking at intermediate power, this one has a distinct appearance compared to the biopsy. So it's got much more basaloid appearance, and it has this basement membrane sort of chondromyxoid-like material. And then at high power, you see a significant number of mitotic figures, even in the post-neoadjuvant setting, with some higher grade nuclear features as well. And so I reviewed this with another pathologist, and we decided to call it an invasive breast carcinoma with features of a matrix-producing metaplastic carcinoma. The RCB index was 2. It was triple negative, GATA3 in this case was negative, but SOX10 was strongly and diffusely positive. I also did TK5 and P63, which both showed weak and patchy expression. There were 2 lymph nodes that were excised in this case, and both were negative for malignancy. And so I'll use this opportunity to discuss matrix-producing metaplastic carcinomas. The WHO defines them as an invasive breast carcinoma with a direct transition to chondroid or osseous extracellular matrix without intervening spindle cells, though it does leave a little bit of room for interpretation on that front by noting that you can have some spindle cells present. And then differential diagnoses are typically other tumors that can produce a similar matrix. So sarcomas, which are rare and lack epithelial differentiation and do have malignant spindle cells. You can have malignant adenomyoepitheliomas, which are biphasic tumors and typically have a transition to a conventional adenomyoepithelioma. Adenoid cystic carcinomas are also biphasic, and they're usually lower grade. And they tend to have a more distinct architectural pattern, so either cribriform, reticular tubular, or solid. And then one of the things that I was thinking about when looking at this tumor at low power was a pleomorphic adenoma because it was quite well defined. These are also very rare, and they lack significant atypia or mitotic activity. Metaplastic carcinomas have a pretty negative prognosis. 5-year disease-free survival is only about 45%, compared to 71% for invasive ductal carcinoma and 60% in triple-negative carcinomas, according to at least one study. And even though they do tend to have poor response to chemotherapy, metaplastic carcinomas are frequently treated in the clinical setting with neoadjuvant chemotherapy, in part to reduce the size of tumors to make surgery easier, and also to evaluate treatment response, as pathologic complete response is associated with a better prognosis. Of note, triple-negative carcinomas with a higher density of tumor-infiltrating lymphocytes are associated with an improved response to neoadjuvant chemotherapy. In terms of matrix-producing metaplastic carcinomas, compared to other forms of metaplastic cancers, they tend to have a better treatment response, but nonetheless, they are usually not highly responsive and are less likely to show a pathologic complete response compared to TNBCs of no special type. Excuse me. And now there's some new evidence that suggests a potential benefit of adding immunotherapy to chemotherapy in the neoadjuvant setting in stage 2 to 3 tumors, which in this case wasn't pursued because the tumor was quite small. And so just to summarize, matrix-producing metaplastic carcinomas can be found alone, or they can be admixed with an invasive breast carcinoma of no special type. And there can be variable tumor responses. And so that's what we suspect likely happened in this case, where the conventional no special type tumor responded better to the neoadjuvant chemotherapy. And what we had left on excision was, in fact, the matrix producing component. These are some references, and I'm happy to answer any questions anyone has.
Thank you, Boris. Let's see, I don't know if you've actually mentioned it in your presentation. What proportion of the kind of in your residual invasive carcinoma is made up of these matrix producing cancers?
In this particular case that I had, that was 100% of the
They're
residual
all,
tumor.
okay.
Yeah.
So you don't see the kind of conventional invasive ductal at all.
That's correct, yeah.
And did this actually generate a discussion with the clinician about like altering their treatment in any way, or?
I don't know yet because I only signed it out last week.
All right.
But we've had cases of biopsies which have had a metaplastic component, and those ones seem to invariably generate discussion at MCC rounds where the clinicians often ask about the proportion of conventional to metaplastic. Because typically the metaplastic doesn't respond as well to chemo. And so they're trying to decide whether or not to go ahead with surgery up front or to treat with neoadjuvant chemotherapy.
Interesting. So in those discussions, do they talk about a particular threshold that they use in making that decision?
I don't think they've asked for a specific threshold, but we've had a case, for example, that was about 50-50, and that generated quite a bit of discussion amongst the clinicians as to whether or not it was worth treating with neoadjuvant chemo. I think obviously the higher the proportion of conventional ductal carcinoma, the more likely they would be to pursue neoadjuvant therapy.
Yeah, and I would say that that's exactly when they are on the verge. They're contemplating whether or not neoadjuvant is suitable for the case, and they know that there is maybe significant metaplastic component. They would opt to operate up front if the tumor is not very extensive, because sometimes in our center they would offer neoadjuvant even for non-locally advanced. So the tumor doesn't necessarily need to be node positive or very big in order to be considered for upfront systemic therapy. So I think that for them, especially for those cases where it's not a real LABC, is just a triple negative tumor, this information may tip the decision to go with surgery upfront. So it is a useful information to provide on your pathology report for core biopsies.
Don't see any questions in the chat. So thank you, Boris. And we'll move on to the next presentation. So next we'll have Dr. Moreen Haddad will be presenting the next case.
Okay, so my name is Moreen. I am a breast pathology fellow at Sunnybrook Health Science Center, and I'm presenting an interesting case that I have very recently encountered here at Sunnybrook. So some history about the patient. This is a 55-year-old lady who previously in 2004, she was found to have DCIS of the left breast that was managed with lumpectomy, adjuvant radiotherapy, and hormonal therapy. 10 years later, she developed DCIS in the contralateral breast. Again, it was managed with lumpectomy and sentinel lymph node biopsy, which was negative, as well as adjuvant radiotherapy. Couple of years later, she was found to have recurrence in the left breast, and biopsy showed invasive breast carcinoma, described as with papillary and micropapillary patterns, but there were no other descriptions about this tumor in the report, and it wasn't done in-house. The patient decided to have bilateral mastectomy. And also she had left sentinel lymph node biopsy. In the mastectomy of the left breast, there was encapsulated papillary carcinoma, nuclear grade 2. It was located in the lower outer quadrant, and there was adjacent conventional intermediate grade DCIS. ER and PR in the in situ carcinoma was positive, margins were widely negative, lymph nodes were negative, and there was no invasive carcinoma in the mastectomy. She underwent genetic testing and it was negative. Most recently, the patient noticed a small nodule, clinically measured less than 1 centimeter in her left anterior axilla, that, according to the patient, was slightly increasing in size over the past year. She didn't have any overlying skin changes. An ultrasound was done and showed in the low left axilla, there is a small nodule measuring 7 millimeter that was hypoechoic with smooth, mildly lobulated margins with some internal vascularity. It was located deep to the skin and, according to the ultrasound, appears to partially invade into the skin. So they recommended ultrasound guided biopsy. So this is what we received. We have few cores and fragments. A few of the fragments showed this benign morphology, which can be interpreted as either benign ectopic breast tissue in the axilla or maybe some sweat glands. Other fragments like this were consistent with a cyst wall, and we can see it's lined by these polygonal cells with eosinophilic cytoplasm, and admixed with them, we have a few mucinous cells. And then we have the main lesion here, which from low power, it has papillary architecture. One of the cores here, it's giving a hint of a well-circumscribed border for this lesion. On higher magnification, we can see the lesion consisting of these sheets of polygonal cells, mainly having this amphiphilic or eosinophilic cytoplasm. Few cells have some kind of clear cytoplasm as well. There was no necrosis or mitosis, but we can see these kind of hyalinized fibrovascular cores in the background. Then there were few areas like this where there is a hint of some ducts or glandular structures that are lined by these cuboidal cells. So at this point, the differential diagnosis included either a skin adnexal neoplasm or maybe a primary or metastatic breast lesion. And also because of the papillary architecture, we wanted to rule out metastasis of papillary carcinoma from other organs. So we did a panel of immunohistochemistry. The tumor was a positive for CK7 and CK56. As we can see, it's diffusely positive. It's positive also for GATA3 and showing patchy positivity for ER. It was negative for CK20 and PAX8. And then we have also this cocktail stain that has smooth muscle myosin, P63, and low molecular weight cytokeratin. And if you're not familiar with this cocktail stain, so the pink stain is low molecular weight keratin, and it's showing diffuse positivity. P63 is the nuclear brown stain, and again, it shows diffuse positivity in the lesion, but it spares some of these ductal and glandular structures that are more obvious here on this stain, and smooth muscle myosin is negative. So at this point, we were thinking about hydroadenoma, and we showed it to a dermatopathologist who agreed with the diagnosis. And this was signed out as skin adnexal tumor favoring hydroadenoma. But surgical excision was recommended to exclude hydroadenocarcinoma. So hydroadenoma is a benign sweat gland neoplasm with ductal and glandular differentiation. It has wide anatomical distribution, but most commonly seen on trunk and limbs. It's rarely seen in the breast or axilla, and there are about less than 40 case reports in the literature. These can create diagnostic challenges on biopsies from these areas. Clinically, hydroadenoma presents as solitary, slow-growing, well-circumscribed mobile nodule. The size range from 0.5 to 3 centimeter, but there are cases with size going over 10 centimeters. They are usually covered by normal epidermis, but skin changes such as discoloration, thickening, and some discharge or ulceration can also be seen. Hydroadenoma, similar to mucoepidermoid carcinoma, have CRTC1 mammal2 fusion that's seen in up to 75% of the cases. Histopathologically, the lesion is well circumscribed. It may extend into the subcutaneous tissue, but it mainly is seen in the dermis. These are usually solid lesions with lobular architecture. Some can have large cystic spaces with eosinophilic material due to degeneration of tumor cells. The majority of these tumors are composed of clear glycogen-rich cells, hence the name clear cell hydroadenoma. And the cells can have small, round, eccentric nuclei. But other cell types can also be seen similar to our case. These include polygonal, mucinous, oncocytic, or epidermoid cells with variable proportions from case to case. Ductal and glandular differentiation are common in these lesions, and these are lined by cuboidal or columnar cells with eosinophilic luminal cuticle, which wasn't very obvious in our case. Hyalonized stroma can be seen separating epithelial islands, which can become very marked in long-standing lesions. We can see atypical features such as irregular borders, increased mitosis, necrosis, and nuclear pleomorphism. And in these cases, it is essential to rule out a hydradenocarcinoma. Regarding the immunoprofile, EMA and CEA can highlight the ductal differentiation. These lesions are strongly positive for P40, P63, CK56, and pankeratin, and they are usually negative for S100 and smooth muscle actin. Regarding malignant transformation, so this is very rare, and usually the histology of hydroadenoma alone is not reliable in predicting the progression. The features of malignancy that are concerning include nuclear pleomorphism, increased mitotic activity, desmoblastic stroma reaction, infiltrative growth pattern, deep subcutaneous invasion, necrosis, perineural invasion, and lymphovascular invasion. And you can see example in the pictures that I took from this paper published by Nazarian et al. In 2009. Hydradenocarcinoma can be difficult to distinguish from hydroadenoma, especially in biopsies. The reason include that 1/3 of the cases can actually show residual benign hydroadenoma that can be seen more toward the surface or mid-portion of the lesion. While if the lesion is excised, we can see infiltrative base, which is a defining malignant feature. Clinically, very rapid growth of a longest-standing hydroadenoma may indicate a malignant transformation. Hydroadenoma are managed by complete excision because recurrence is seen when there is inadequate excision about 12% of the cases. And complete excision with a clear margin is important to decrease risk of recurrence and ensure accurate final diagnosis and to enable appropriate treatment. These are the references I used for this presentation. Thank you for listening. And if you have any questions or comments, please go ahead.
Thank you very much, Moreen. It's an interesting case. It's very easy to forget that we have to consider other possibilities such as skin and axil tumors as well. There is a question in the chat, and it's about how would you go about explaining the ER positivity? And also, was AR positive in this case as well?
Yeah, we didn't do AR. I believe AR would be positive in lesions that are of apocrine differentiation. Most of hydroadenomas, according to the literature review I conducted, are of believed to be of acrine differentiation. So I'm not sure if they will be positive for AR. Regarding ER positivity, I think some adnexal tumors can actually show expression of ER, PR, and HER2, which complicate the picture for us if the differential diagnosis include breast versus adnexal neoplasms.
And then there's another question, morphologically, within adenoma epithelioma be considered as a differential in this case?
Yeah, that's one of the differentials for hydroadenoma, especially if it's located in the breast or if we suspect there's ectopic breast tissue in the axilla, similar to this case. But we saw that P63 is positive around these ducts and glandular differentiation areas, but smooth muscle myosin was negative, which in adenoma epithelioma would be positive. So based on H&E alone, yes, adenomyothelioma would be in the differential, but the stains ruled that out.
Any other questions or remarks? Thank you very much. We'll move on to our next case, which I will be presenting. Right. So this is a 79-year-old woman who had a 10-month history of right breast pain. Excuse me. So she actually had mammograms and ultrasound when her pain started, and both imaging were normal, but the pain was progressively getting worse. So her doctor arranged for another imaging to be done. Her past medical history is significant for gastric carcinoma, that's PT1A and X, back in 2018, and she also has rheumatoid arthritis. Her ultrasound in July of this year shows a hypoechoic vascular area with slightly irregular borders and a central echogenic component, and it measures 9 millimeters in size. There was a question whether this represents an intramammary lymph node. In the axilla, there was no lymphadenopathy. So unfortunately, I don't actually have the biopsy images for this case. They are, we sent this case out for a consult. Actually, we're still waiting for those to come back to us. But I do have the imaging from the excision specimen, and morphologically they look the same. So I'll be presenting what this shows on the excision. Okay. So this patient ended up with an excision of her right breast, and on low power here, you can see kind of fairly solid looking areas, very hyperchromatic looking, and higher power, you can see that they look a little bit basiloid-like. You have these kind of medium to large nuclei. You can barely see any cytoplasm, and it's pretty uniform throughout the whole lesion. Mitoses are fairly readily identified. And again, they're very, very easy to spot over the place. There and there. There. Okay. And there's no lymphovascular or perineal invasion identified. So we ended up, so this looks like some kind of basiloid neoplasm, and we ended up doing a lot of immunostains on this case. So here we have CK7, which you can see kind of diffuse, pretty strong staining. CK5, it's a little bit more patchy, but there's still some staining there. CK20 is negative. This is our dual stain for myoepithelial cells. And you can see that it highlights some of the nests that we can see, indicating that there's probably an in situ component. Okay. This is key 67, looks quite proliferative. ERPR, HER2 are all negative. GATA3 is also negative. SOX10 is strongly positive. S100, it's a little bit more patchy and weak in comparison. Synaptophysin and chromogranin are negative. and so is CD56. We also did TTF1 that was negative, and CD117 was positive. Okay. So in summary, we have immunoreactivity for CK5, CK7, CD117, SOX10, S100. I didn't show the EMA, that it does show kind of really rare cells to be positive, and it's negative for CK20, GATA3, TTF1, CD56, synaptophysin, and chromogranin. And again, this is triple negative. Okay. So based on the morphology, we ended up calling this a kind of a basiloid neoplasm with an in situ component. The differentials include kind of solid basiloid adenoid cystic carcinoma, invasive carcinoma of no special type, small cell neuroendocrine carcinoma, metastatic basal cell carcinoma. And of course, these are kind of based more on the morphologic appearances. And with the immunoprofile, we favored solid basiloid adenoid cystic carcinoma. And we sent this case cells for a consult for additional testing. And in addition to all the immunos that we've done, the institution kind of performed a MIP immuno that was positive. However, the molecular testing showed that there's no variant in kind of any of the established clinically significant category. Okay. So the final diagnosis is a solid basiloid adenoid cystic carcinoma. Okay. Okay. So I'm going to talk about adenoid cystic carcinoma first. So this usually affects elderly women. It is pretty rare. It occurs in 0.1 to 3.5% of all breast tumors. Microscopically, they tend to be quite well circumscribed nodules. And adenoid cystic carcinoma is divided into 3 subtypes. There's the classic type, there's solid basiloid, and there's also adenoid cystic carcinoma with high-grade transformation. In the interest of time, I'm not really going to talk about this third subtype here. And kind of this is your kind of classic adenoid cystic carcinoma. I'm sure you're all very familiar with. This basically shows the same morphological spectrum as you would see in salivary gland. Okay, and this is also the most common variant, and it's composed of a mixture of kind of tubular, cribriform, and solid patterns. And here we see mostly the kind of cribriform pattern. And in classic adenoid cystic carcinoma, so in this variant, the cells kind of lack really marked nuclear atypia. You don't really see necrosis, and it's pretty hard to spot mitosis. Okay. Sometimes you can see an in situ component. Okay. And as you know, the adenoid cystic carcinoma is composed of both epithelial and myoepithelial cells. Here I have an image. So this is once again a H&E of adenoid cystic carcinoma with a dominantly a cribriform pattern. Okay, and in slides, in images, and B, C, and F here. So here you can kind of see the luminal cells around the kind of the true glandular spaces being positive for EMA, CK7, and CK56. Okay, whereas in kind of P63 and collagen type 4, you see the staining kind of in the abluminal cells around the pseudolumen. Okay. And excuse me, moving on to kind of solid basaloid adenoid cystic carcinoma. This is kind of characterized by these quite solid nests composed of basaloid cells with quite marked nuclear atypia. And as we've seen before, high mitotic count, and it's not unusual to see necrosis as well. Perineural invasion is not an infrequent finding here. And as we mentioned previously, kind of in the differential diagnosis, these should be differentiated with from carcinoma with any kind of basaloid morphology. So things like small cell neuroendocrine carcinoma is in the differential as well. And this is why we do kind of our kind of neuroendocrine markers. And one thing that you can help differentiate is you can try and look for kind of more typical adenoid cystic carcinoma areas, but that is actually not present in our case at all. And here is a really nice imaging of, so here I have image of a kind of a conventional type adenoid cystic carcinoma with MIP arrangement. And the column down the middle here is adenoid cystic carcinoma without MIP arrangement. And finally, you have kind of more kind of solid basaloid adenoid cystic carcinoma. Okay, and so if we kind of look across here, you can see that the P63 is kind of staining the myoepithelial cells in the conventional type adenoid cystic carcinoma, while it's kind of absent in the solid type. Okay, and so this is the MIP staining, as I mentioned. So these first, so this one here has MIP rearrangement. Okay, and this one here is actually without MIP arrangement. And interestingly, it's also diffusely positive in the solid type adenoid cystic carcinoma. And when we look at CK7 staining, you can see that it's positive in the epithelial cells of the conventional types. And then in the solid type, it kind of highlights the kind of intercalated duct-like structures kind of within the in the tumor islands here. And then moving kind of onto molecular testing. In the vast majority of the cases, we expect to see MIP and Fib fusion gene. And this is very similar to what you see in the kind of salivary gland counterpart. So you would see that in the majority of adenoid cystic carcinoma cases, including the solid variant. However, in solid variant of adenomyocystic carcinoma, you can actually see Notch or CREPP mutations as well. So it seems that they are kind of a fairly distinct molecular entity. In terms of prognosis, we're kind of comparing kind of classic adenomyocystic carcinoma versus solid basaloid adenomyocystic carcinoma. Both local and distant metastases are pretty rare in classic adenomyocystic carcinoma. And usually, in terms of treatment, surgery is more than sufficient. Whereas in solid basaloid adenomyocystic carcinoma, you have more frequent local metastasis. It's not unusual for you to find axillary-renal metastasis. And in rare cases, they can also go to the lungs and bones. In terms of treatment, there's pretty scant data, but if there's recurrence, adjuvant chemotherapy can be considered. The reason why I've brought this case forward to the meeting is, interestingly, this case was discussed at our tumor boards recently because the oncologist wasn't quite sure how aggressive they need to be in terms of their treatment. And in this particular case, they kind of decided to kind of stay with the just stop at surgery and not pursue any additional therapy, and kind of take a more watchful waiting stance in this case. All right. So does anyone have any questions they want to raise?
Hi, Jessie. Hi.
Yes. Hi.
This is Fang. Hello.
Hi.
Nice presentation. I just have a question. I think you mentioned that there is like an in situ component.
Yes. Yeah.
I just wonder, how do you define in situ adenomyocystic? Because I remember I had a similar case, and actually my case, the whole lesion is very well circumscribed, and so I was wondering about like in situ lesion, and I showed to a head and neck pathologist, and then they're like, "Oh, in head and neck we don't call in situ adenomyocystic." And I was wondering, like, how do you define that in breast, and they don't call it in head and neck?
Yes, I've had similar questions before as well. I think I saw Silva's name here as well, who's a head and neck pathologist. So maybe she can jump in and offer her 2 cents.
No, I agree. I've had trouble with in situ because we don't call it in the head and neck region. So usually, I remember we had a case where the outside institution had requested HER2, and they had also called in situ as well. The outside institution had, and so when we interpreted the HER2, we kind of focused on the areas that were sort of like smaller nests out infiltrating into the fat, because I also don't call it in situ, and so I wasn't sure what to make of the area that the outside institution had called in situ, and they wanted interpretation of the HER2 in like quote unquote both components. So we decided to just kind of focus on the little nests outside, because I said I'm not comfortable with this in situ concept in the breast, since we don't really call it in the head and neck.
Jessie, can you go to your presentation? I think that when you showed your cocktail or P63 IHC, there were some ducts where you actually saw P63 decorating very nicely the periphery of those nests, as opposed to other nests where the distribution was a little bit different. So I think you had something that was distinct.
Yeah, so this is
you're no longer sharing the are you
sorry.
sharing? Yeah.
Am I not sharing?
I think you're not. I don't see you.
Okay. Sorry. I thought I was. Just give me 1 minute. Oh, I think this is probably the image that you're talking about here.
Right. So you see what I mean? You have at least two ducts where you have a fence of P63 positive cells, while the others are not as nicely limiting the nest. I mean, I would imagine that those were considered in situ.
It is pretty interesting because I was really confused by this whole concept of the in situ component as well. And I kind of looked through various textbooks. Only like, I mean, WHO does mention that rarely you can see an in situ component, and I saw it in another textbook, but other than that, no one makes any mention of it. So yeah.
Yeah, especially in like, well, I guess your case is like really distinct staining. In my case, the whole thing is solid basal and it's quite well circumscribed, the whole lesion, but it's solid basal. So poor prognosis if you're calling the whole thing invasive, but if you're calling it in situ, then maybe less poor prognosis. So anyway, just, yeah, I feel like that area is not very well defined.
Yeah. And we have Dr. Van Bockstal here, and she is an expert in DCIS. Maybe she can pitch in from her experience if she's still with us. Maybe she's not. Okay, that's okay.
I think that's all the time we have.
Yeah.
Should we wrap things up? And, thank you for to all the presenters. It's really, really interesting cases today. Anna, do you have anything you want to say before we finish?
Yeah, I just want to remind everybody to fill out evaluation forms, and I would like to thank all the presenters and Dr. Van Bock for amazing presentations. Thank you, Sharon, for your input, and of course, Jessie and Rachel, exemplary work. Thanks so much, and see you in a bit for our next communities of interest. And if we don't see you till the end of the year, everybody happy holidays, enjoy your time, and see you next year. Bye now.